Hi, everyone, and welcome to today's presentation / webinar on Oklahoma's Peer Recovery Support Specialist Crisis Track Training. Before we begin, we'd like to give a special thanks to SAMHSA for sponsoring this presentation. There are a few housekeeping items I'd like to quickly go over. This presentation is being recorded, and the recording link, slides, and a letter of attendance will be sent to everyone who attended today and will also be available on NASMHPD's website. If you need closed captioning today, a link will be available in the chat pod for all questions and comments. Please also type those in the chat as well for any questions and comments. There is a part 2 for this webinar that will take place via Zoom on Thursday, July 14th from 1 to 2 p.m. Eastern Standard Time. This will be an opportunity to continue today's discussion in a more intimate setting. We'll share the registration link for part 2 in the chat box throughout the presentation today. There will also be a brief survey after the presentation, so if you could stay on to click that link to complete the survey. Thank you again for joining us, and I will now turn this over to today's presenters, Tony Stelter, Director of Recovery Support at Oklahoma's Department of Mental Health and Substance Abuse Services.
Hi, good afternoon or morning, I guess, depending on where you're at. Thank you for that introduction page. I'm glad to be here and glad to get to talk with all of you, and I appreciate y'all registered for this and coming on. I'm excited to talk about peer support in crisis services and the training that we've created in Oklahoma. Yeah, like Paige said, I'm Tony Stelter. I'm the Director of Recovery Supports at the Oklahoma Department of Mental Health and Substance Abuse Services. I'm a person in recovery, which I'll talk a little bit about more here in just a minute, but I'm also a certified peer recovery support specialist in the state of Oklahoma, and also I'm a licensed professional counselor. In case you didn't know, I'll go ahead and share this with you, but you are in the ODMH SAS Peer Recovery Support Crisis Training, which is an overview of the training that we provide our folks. And so just so y'all know, if you do have any questions or anything that you can use the raise your hand function, or you can ask stuff in the chat box too, and Paige or Kelly or Amy will let me know of the questions at certain times during the training, and so that I can answer those. We'll also have time, hopefully, maybe for some questions afterwards, but if not, we'll be able to answer all those questions in the second part on Thursday. All right. Well, I guess we'll get going. So what are the learning objectives for this training? Well, hopefully, I hope everyone here has an understanding or an overview of the components of our new peer recovery support specialist crisis track. It's not that new, but it's still pretty new. So the objectives I want y'all to walk away with when you leave is I would like for y'all to understand the history of Oklahoma's crisis response and crisis centers, and also where it's going. What is crisis? These are the objectives also we want our folks that take the training to walk away with. We want you to have an understanding of crisis care and response in Oklahoma, our levels of care that we work with, which are vital when it comes to crisis services. And then also, what's the C-PRSS role, responsibilities, and what professional skills do they need to have in crisis settings, which we go over and help train in our training. All right. I always like, anytime I do a presentation or speak or anything like that, no matter what it is, when it comes to my role, I like to share some of my lived experience. I don't always do it, but I like to when I can, because I think it's so important as far as busting stigma. I think one of the biggest barriers for folks getting into services is, the stigma of going into services. And so I like to share that, despite being in the role that I'm in, I too have lived experience, and I too have been able to overcome that. And if it weren't for services and the help I got, I probably would not be here today. So just real quickly, I want to let y'all know, from a very young age, I suffered with low self-worth. I was a people pleaser. I didn't feel worthy. And I struggled that, and that led to a lot of anxiety and depression. And a lot of, suicide intensity and thoughts of suicide too. And so I remember there was a time when I got my wisdom teeth taken out, and I was prescribed opioids, and that numbed those feelings. And I wanted to keep that going, but the thing is, when you numb the good feelings, you also numb the bad feelings, and things, you're able to sustain for a while, but things eventually progress. And that's what happened with me. Because of this too, there was times when I had, a lot of my suicidal thoughts got worse because I didn't think there was a way to stop it, and I actually had an attempt, which I'm very lucky I survived. And then I've also too have dealt with, due to that addiction and, just loved ones and everything like that, I've dealt with a lot of suicide loss in my life too, losing folks to suicide. I was eventually able, I had a really supportive family, and luckily because of that, they were a big part of me finally deciding to get into treatment. And since then, life has been like a rocket ship. I've gotten to recovery. My kid's mom, she gave birth to my son. That was one of the best things ever. And because I've been in recovery, I've been able to be a dad to my kiddo, which is, my most important job. My self-worth, has gone up, since I finally learned that, I need to love Tony, and that was a big part of it. And it's still a constant process, but something I'm working on. Wellness and self-care is a big part of my recovery. I just ran a marathon back in April. I love running. It's like a big part of my recovery that overall, it's my big part. And then also I've been able to have a fulfilling over 11-year career in behavioral health services. And 5 of those was in crisis care. I served as the director of a crisis center here in Oklahoma County, which is, the biggest county and most populated county in Oklahoma. And that helped, that was really fulfilling until I got into this role, which is, I'm able to use some of that too to help train peers, and then also in other aspects of my job too. So just want to share that with y'all, and we'll keep going here. So what are we talking about today? We're talking about the crisis training, and I think it's important to talk about the development. So if you're wanting to do something like that in your state or within your agency, this is what we did. We developed this because we saw a need, we saw a gap. I researched and tried to find other trainings that were really encompassing, that would meet the needs in Oklahoma, and I had a hard time finding it. I found some trainings that would just address suicide or just address like certain issues, but nothing that was, kind of all encompassing and that was really directed towards peers. And this was about a year ago when we started this development, or over a year ago. So we wanted a training that wasn't just, I know 988 is a big deal right now, and those mobile crisis response teams and things like that. But we also have, a lot of crisis services that have existed for quite some time, with crisis centers and urgent recovery centers, which we're going to talk more about too. And we wanted to have a training that worked for those folks as well, because those have been well established. So we did 2 focus groups with folks, with peers, certified peers from across the state, both peers that are working in crisis service or have worked in crisis service, and also some of our peers that have experienced crisis services themselves. And so we use those focus groups to really take what they were telling us and use that and information to make sure we created training that met those needs. We also had a focus group that included crisis level care directors. So folks that were directors of crisis centers and URCs, urgent recovery centers across the state of Oklahoma too. So we used our expertise, like I have the experience, like I said before, as a peer, as a clinician that worked in crisis services doing assessments for years, and also a director, to take all this information, as well as our team who have worked in many different aspects of peer support, whether it be recovery community organizations, outpatient services, and things like that. So we took that, and that's what we used to create the training, all of our experience, and that's how it came together. We did some beta testing, or our pilot with peers that are currently working in the crisis level of care and crisis director. That was our first one, and we got great feedback. And so we've done 4 more trainings after that since then, and we'll talk more about that here in just a bit. So just so y'all know, how do we implement our training? It's virtual. So we serve peers from across the state. We've noticed that, since the pandemic had a lot of bad things, but we've also had some great things come out of it where we've learned to adapt and use that. So we find that doing the training virtual, it cuts down a lot of barriers for our peers that may have kids. And so travel's an issue. They're able to stay at home and their kids. And we've seen that it's actually been really effective as far as what they walk away with in the content, and if they've retained that content. We offer this free to our Oklahoma certified peer recovery support specialists. We usually set our max at 50. We find that if we get over 50 for our trainings, it starts to get a little bit hard to answer questions and everything that we want to do to make sure that training is effective and that folks are walking away with all the information they need. We're doing this training every other month. We've now put it to a quarterly training, just due to we do lots of training, so we have to make sure that we're giving it equal time to all those too. So we started out every other month to make sure we got those initial folks that are working in crisis right now taken care of, and then now we're offering it quarterly. We would definitely be willing to do special trainings if needed, if there was an urgent need. The training's 2 days. And then also most agencies and facilities that are working within our state system are requiring or strongly encouraging their peers that are working in crisis level of care to take this training. All right. I do want to let y'all know we are going to take a break, like a 10 or 15-minute break about halfway through. My attention span, I was telling Kelly and Amy and them this before, and Paige this before, but yeah, I can't hardly do a full hour. So I know y'all probably can't too. And I'm sure y'all want to take a break from listening to me for just a little bit, so you can take care of some things and stretch and go to the water, get a water, or go to the restroom. So we're going to do that. So don't worry. I really love this quote, and we share this in our training as well, that every little thing counts in a crisis. And this was a quote by, I'm not going to say his name because I know I'm going to butcher it, but he was a leader in India's anti-colonial movement in the 1930s. He was imprisoned at one point and served as prime minister, so he knew what it was like to be in a crisis. So and I just think this quote really fits with what crisis services are about. It's about even those little small things make a huge difference, and we really push that in our training. All right, so now we're going to talk about the history of crisis services in Oklahoma. And also, by the way, I did mention to y'all I'm a dad, and so my kiddo is 13. And if y'all have been around any 13-year-olds, like their parents are super cringy. So I like to also make it worse and tell bad dad jokes, so he cringes even more. So I'm probably going to share some of those with y'all. I'm going to share one right now. How do you weigh a millennial in Instagrams? So, all right. So I apologize right now, but y'all are going to have to hear some of those. So the first thing I was going to talk about is the history of crisis services in Oklahoma. So I think it's important to talk about deinstitutionalization. We share this in our training too, the deinstitutionalization that took place with the 1963 Community Mental Health Act when they signed in, which basically folks, as you all know, I'm probably preaching to the choir, but you all know folks used to be institutionalized for long periods of time. People were just there, and they would be there for years and years and years, and sometimes when they shouldn't be. But what happened with deinstitutionalization is, it was a great thing in a lot of ways, but sometimes I don't feel like we necessarily were given all the resources, and folks weren't given all the resources to prepare for that. And so, that's where a lot of, the peer movement came out of, it was due to that, organizing due to like the mistreatment and making sure that never happens again, and also coming together to provide support to each other after this institutionalization happened, and that after, once deinstitutionalization happened, to provide support to each other, and which was a big thing. So also coming from that, we realized like we created these community mental health centers, but there was still a need like in between that. We wanted to have this least restrictive care. And so rather than just putting someone straight into an institution, like there should be another level of care there, which kind of birthed the crisis centers. So in Oklahoma, prior to 1982, in between this stage after deinstitutionalization, Oklahoma County residents, if they needed emergency mental health services, they were either arrested on minor charges and they were put in jails, which is not, we know that's not the best place for treatment, right? That's not what having mental health issues isn't a crime. Or they would remain at home, like in the family member or friends, or, helping them, which sometimes, is not always the best case scenario either, or they would be, homeless or at large in the community. So in 1982, though, and so you had to actually be placed on an order of detention in order to be placed into a mental health hospital. And so, so in July 1987, the Department of Mental Health, we decided we were going to establish the current crisis care system. So, and this was funded and operated by the Department of Mental Health and Substance Abuse Services in Oklahoma. And what this gave is another level of care for folks that were in the community to be able to go to or to be brought to, that wasn't necessarily going straight to a hospital, but a place where they could go and receive assessment and treatment at a lower level of care. If they need care that's above that community-based care that's just a little bit higher, they're able to receive that assessment and not necessarily have to go into an institution at that time or a mental health hospital. It took a lot of burden off, the community and also those community resources, and it added some vital care that was needed. And it's been growing ever since. So in late 2011, here in Oklahoma, we had been running this crisis center. And so we had, whenever there was the Institute for of Mental Diseases and CMS made it so there had to be 16 beds. So we actually had many beds. We had to split it up so that we had to make it 2 units. So we had 2. And then we also started having some growth beyond that too. But since then, we've asked for an IMD waiver. We've built many more crisis centers that were 16 beds, but we've asked for an IMD waiver so that we no longer have to just have that 16 amount, and that lasts until 2025, which I'll talk about more. So it's growing. I'm gonna go ahead and move on to the next slide because it's gonna make more sense with what I'm about to say. So here's some of the crisis care locations in Oklahoma, and this is supposed to grow by 50% more within the next few years too. We have a lot more that are currently in the process of being built or may have already been started running that I just haven't added yet on here. But currently right now we have crisis centers across the state. We have some in Oklahoma City, which I was just talking about, which were our first ones, which were these 2. We have Cree Oaks, which is in Sapulpa, Oklahoma. We have, Green Country Behavioral Health Services operates in Muskogee. We have our Family and Children's Services, which is a big provider in Tulsa, has one. We have them all across the state. We also have some crisis stabilization services for kids, for those under 18. Not enough, as you can see, but we're hoping to get some more of those too. We have urgent recovery centers, which I'm going to talk about more what that is here in a bit, but some are attached to crisis centers, and so we have some that are freestanding. One of the newest ones we have is Hope's in South Oklahoma City, which is really exciting. It's going to take some of the burden off of the other ones that we have in Oklahoma City. And then I also included inpatient hospitals too, and these are our state-ran inpatient hospitals. I did not include the private ones. All right. So whenever we're talking about our training, talking in our training that we were providing to our certified peer recovery support specialist in Oklahoma. We go over what a crisis is. And so this is that standard definition, which is a mental health crisis is any situation in which a person's behavior puts them at risk of hurting themselves or others and or prevents them from being able to care for themselves or function effectively in the community. And that was NAMI's definition. And then there's also, if you're just going to go by the old Merriam, it's an emotionally significant event or radical change of status in a person's life. This generally leads to a good discussion within the group, within the training, about what they feel a crisis is. And we talk about how we're talking about crisis as it relates to a mental health, behavioral health crisis. All right. We understand that working, as a peer, sometimes our job's not necessarily to know what, all the crisis terminology or, clinical terminology or things like that, but we're going to be hearing them in these settings. And so we felt it was important that, in our training, we were going to prepare our peers that are either already working in the workforce or going to be working in the workforce, so they were prepared and have an understanding what that is. So we also provide folks with a training manual that also includes these, but we go over them as well. These are some of those terms that we go over. We talk about antidepressants, antipsychotics. We talk about what like hallucinations, auditory versus visual, and what that means. We go over what clinical means, like cognitions. These are all terms that folks will be hearing whenever they're attending whenever they're working in crisis settings. They're going to hear them whether they're working on a crisis unit or an urgent recovery center. They're going to hear them, when they're serving on a treatment team, which they should be, or on a response team in the community. So these are all things they're going to be hearing. We talk about, of course, depression, delusions, dual diagnosis, co-occurring diagnosis, early interventions, emergency detention, which is what we call here when someone is placed into involuntary into treatment. We talk about evidence-based practice, first episode psychosis and what that means, intervention, mania, mood disorders, we go over several of those, psychosis, schizoaffective disorder, schizophrenia, and of course, recovery. We're kind of preaching to the choir on that one because everyone that takes our training is already certified as a peer recovery support specialist. We took all these too from the National Institute of Mental Health, their glossary. All right, so also in our training, we feel it's important to talk about, of course, when it comes to crisis services, suicide. We start off when we're teaching the training with this quote by Martin Luther King Jr., which is by, I know somehow that only when it is dark enough that you can see the stars. We do give a warning that some of the information, because it's going to be hard to hear and it could be triggering for some folks or activating for some folks. But we cover suicide, what that is, the statistics, and how it affects the population, because we feel like you have to know that and have a good understanding of that. So when you're providing service, you're providing that most competent care. And so we go over, like I said before, we go over the definitions of what suicide is, which is a death caused by self-directed injurious behavior with intent to die as a result of the behavior. We talk about suicide attempts. And then we also talk about the definition of suicide ideation or intensity. We give some facts, that we got according to the CDC, which here are some pretty startling ones. Like suicide in 2020, suicide is the leading cause of death in the United States with 45,979 deaths. It's about one death every 11 minutes. This usually hits folks pretty hard when we're doing our training. This really puts into the point of how important crisis services are and what we're doing as peer recovery support specialists, or just those working in the behavioral field, how important it is with what we're doing, how much of an impact that is. We talk about how in 2020, an estimated 12.2 million Americans adults seriously thought about suicide, and 3.21 million planned a suicide attempt, and 1.2 million attempted suicide. We talk about how people who have experienced violence, including child abuse, bullying, or sexual violence, have a higher suicide risk. And we also talk about how suicide was the second leading cause for death for people ages 10 to 14 and 25 to 34, which is big. It's not just affecting, that older folks or folks like middle-aged folks, or it's affecting our young folks too. So we also cover statistics, specifically in our training related to Oklahoma. We talk more specifically about statistics in our training about youth and young adults. We definitely hit on veterans. That's a real big important part. We have lots of initiatives too. We talk about here in Oklahoma regarding these populations and what we're doing to try to help that. We talk about the LGBTQIA+ community, and then we also talk about suicide rate by ethnicity, and how it impacts each group. We usually have a discussion too, or in a pretty robust one following this part of the training, where one of the prompts we use is, does any of this information surprise you? We usually get a lot of folks saying, yes, I didn't know about this, and yes, this. And so it really helps folks think about, the big picture, and, get out of maybe just their viewpoint and realizing how widespread, how much folks are affected by this, which is a really important thing to know and to have perspective on when you're going to be providing services to folks that are being impacted by this, that are dealing with suicide loss, suicide attempts, suicide intensity, or in their lives. All right. And I'm going to go back and answer some questions real quick that I see in the chat. So, does this training lead to certification of a peer specializing in crisis work? So Clarence, this training, what this does is we require CEUs, and this isn't a certification. It's just it's a CEU or a endorsement, or as you would say, or a specialty track that we provide in Oklahoma for our already certified peers in Oklahoma. Like I said, some of the agencies or providers within our state require it for their folks as part of their training. I should have mentioned this before. So this training is not an end-all training for peers. This is a supplemental training to the training they will also be provided, through their agencies and providers that they're working for, who also will have requirements as far as trainings that they provide for their folks in responding to crisis services and according to their, certifying body or of the agency that they work for. But we wanted to make sure that we're providing also training too for our folks so that they're better prepared and more prepared. Let's see here. Has this training been endorsed by any national organizations? No, not yet. Not yet. It's still pretty fresh and new. So not at this time. Right now, this is for Oklahomans. We've had some talks with some other states that were interested in it. When we created it, it wasn't to create like a training to sell, to other folks. We saw a need in Oklahoma. We do this with many of our trainings. We saw a need in Oklahoma, and we wanted to fill that gap and address that need of this information being and providing a training to our folks that are asking for it. We haven't really sought anything like that out at this time. All right. So next in our training, we talk about stressors. We talk about the different kinds of stressors that can lead to or cause a crisis. We talk about home or environmental stressors. And we talk about like the different things that can cause that, like, changes in a relationship, losses of any kind, conflicts or arguments, trauma, or exposure to violence, discrimination, experiencing homelessness. And we ask folks to also fill in any gaps we may be missing as we're hitting on these things. We talk about stressors of school or work, like worrying about upcoming projects or tasks. We talk about, how feeling singled out by coworkers or peers, feeling lonely, that these are stressors that we face. We talk about lack of understanding from peers, coworkers, teachers, discrimination, failing grades, losing a job. And we always ask for input too of anything we miss. We talk about other stressors such as abusive behaviors to self or others, including substance use or self-harm, like cutting. We talk about isolation from school, work, how that's another stressor that can also lead to crisis. We talk about how psychosis, like losing touch with reality, can also lead to a crisis, paranoia. We hit on all these things. We talk about the signs of a crisis. And how that's really important when you're working in crisis services to be able to recognize that. So some signs that we mentioned, and these aren't all the signs, and just because you have one of these bullet points that I'm about to mention doesn't necessarily mean that you're going to go into a crisis, but these are some signs or warning signs that, hey, we need to pay attention, and some prevention or some services probably need to happen. So if that person's unable to complete, daily tasks like getting dressed, brushing teeth, bathing, etc., that they're normally able to do, if someone's verbally saying, writing, or insinuating that they like to kill themselves or talking about death, that is definitely a red flag right there that person might be going into crisis or is in crisis. Withdrawing from friends, family, and other their typical social situations, showing impulsive or reckless behavior, being aggressive, or having dramatic shifts in mood, sleeping, or eating patterns. We talk about the stages of crisis. And this is really important to kind of be aware of these when you're working in a crisis setting, which is what we teach our folks, because that individuals in that stage one, and I'm in stage one. I live in stage one a lot. These are those kind of minor annoyances that happen and frustrations of everyday life. Usually individuals at this stage, they're rational, so you're in control of your emotions and your behavior. This is stage one. When it moves to stage two, you start having that more heightened condition, and like you can usually see some of the physical aspects, such as rapid heart rate. They might start to appear like they're lost or confused and having trouble with problem solving. So they're escalating. They're moving into that second stage. The person might, the voice might start getting higher pitched too in that stage. Stage three usually is a person's reasoning capacity is seriously diminished. So at this point, like having those, trying to have a rational, logical conversation is going to be hard. And so you have to start keeping things pretty simple and direct, and really start working to prevent, help them calm at this stage. Usually you can start seeing some of the physical things like their pacing, clenched fists, perspirating, shallow breathing. Swearing might be something, shouting. That's when that person has reached that stage 3 of crisis. And then stage 4, which is that person, has lost control, of the ability to be able to rationalize, and they need help at this stage. They really need help. Always too, we teach the goal is to prevent the escalation if all possible. That's the best thing. But this is when that person's gotten that 4, the anxiety or loss of cognitive, emotional, and behavioral control. They have an urgent need to remove in that emotional pain. Usually the behaviors are pretty erratic. And most generally when they've hit this stage, that is when they are an imminent risk of danger to self or others, which in Oklahoma is that criteria for admission into crisis services involuntarily, if that is needed at that stage. Our goal, you can also obviously you can go into crisis services or get crisis services at any of these stages, but when you hit this stage, that means that we are acting, and it's very serious. And so we also talk about how people arrive at crisis centers in our training, which is really important to know, right? We have folks that walk in. We have, this includes, they may be brought by their self, a family member, friend, etc. They come straight into the front door. Folks sometimes are referred by hospitals. A lot of times, especially before 988, and if you're, depending on how, robust of a system you have within your state, some folks go straight to a hospital because that's what they know, or they're brought to a hospital. And then that hospital is like, hey, this is not a medical issue, but this is a behavioral health issue. And I think this person would be better served at a crisis center. a crisis stabilization center. So the hospital will do a referral to get them over. Sometimes IMSA will realize that this is a crisis, a behavioral health crisis, and bring folks to a crisis center. Sometimes folks are referred to by community mental health centers or certified community behavioral health clinics in the community, private clinics as well, like private clinic, medical clinics, private behavioral health clinics as well. Community partners within the community, whether that be for like homeless services or court diversion services or just food bank services, anything like that. All kinds of the partners, they also are a big referral source for crisis centers that work with folks that are in the behavioral health population. Shelters, that's a big one too. Especially from my experience, we would go out and visit the shelters too when I was on our mobile response team. Provide outreach and also respond to crises and also for follow-up. But then also law enforcement is another big one too. And we want law enforcement bringing us folks and not taking them to jail. We'd much rather folks, because that's not where they're going to get the best services. All right, a big important part of our training that we go over is emergency detention versus voluntary. And so in Oklahoma, when folks are, we go, Title 43A is the law in Oklahoma when it comes to emergency detention or voluntary. So, and this is when someone's put into services, going to go into services, maybe against their will. I know each state has different things they call it. I'm trying to remember a lot of times are numbers, that they call it. Like I can't remember, like a 506, or y'all can probably tell me. I don't know what it's called. I know what's it called in California when you're put in to services, but this is kind of what I'm referring to. So in Oklahoma, in order to be placed in emergency detention status, which means that means that person is an imminent risk of harm to self or others. This is when that person, it's a big deal to do this too, because that person's rights are taken away, right? They're put into treatment against their will. In order to do this, there has to be a licensed mental health professional statement stating why that person is meeting that criteria of imminent risk of harm to self or others. And this has to be done by a licensed mental health professional. There's also voluntary status too, which is another way a person can get into, go into a crisis center or a hospital, which is that person is willing to voluntarily admit that they are, but they still must be meeting that ED criteria. If they're not meeting this criteria, they could be served at a lower level of care. But sometimes folks are competent enough, like we said, like on this last one, they're competent enough to understand that they do need help. And they're able to voluntarily admit while still meeting this status. They have to be willing to receive crisis stabilization services. Otherwise, they should be placed in emergency detention status. If someone goes in, we'll talk about that more here in a second. All right, we talk about how, so we go over that even more thoroughly than I just did for the sake of this presentation, which is not a 2-day training. I'm giving you all the quick version, but we do go over it more. All right. We do talk about too, I just want to let y'all know, in Oklahoma, we talk about the crisis center length of stay. According to our law, Title 43A, those in emergency detention status can only be held for a maximum of 120 hours. And that's not counting weekends or holidays too. So that's important to know. We want to make sure that our peers that are going to be working in those settings understand this, because giving folks the wrong information sometimes can cause folks to escalate to or not trust. So we want to make sure that we're giving them the correct information. They know this correct information, and sometimes that's hard. We also really too focus on or train on, if you're not completely sure too, referring them to someone that does know, because just sharing someone information that you think can be harmful, especially if it's incorrect. Usually two, for in Oklahoma, those in voluntary status can stay as long, not usually, but they can stay as long as treatment is the least restrictive and most appropriate for the individual's treatment needs. So on average, at least it was the case at the crisis center I was at in Oklahoma County, that the stay is usually 4 to 5 days. Well, that makes sense, right? Since the 120 hours. We then talk about if someone is not able to did I miss that? Oh, we'll talk about here in a second, what happens if someone's not able to stabilize within that time. So some of the community partners with crisis centers, it's important to know that, because without our community partners, there's gaps in treatment services. Crisis services would not work without having those relationships and partnerships within the community. You can't operate as a silo in crisis services, and peer support is a huge factor in closing those gaps in between treatment and helping prevent those silos from happening, because we provide that outreach, that follow-up, helping folks make sure they get connected to those community partnerships within following discharge, and then after discharge. So we work really closely in crisis services with community mental health centers, certified community behavioral health clinics, medical psychiatric hospitals, both state and private. I work for the state, so that's where kind of like my most knowledge is, but we do work really well with private ones as well. We substance use treatment centers, law enforcement, nonprofits that focus on the individuals we serve that provide services, such as the Homeless Alliance. We have City Care here, Mental Health Association of Oklahoma. Some of those are some of the big ones. There's a lot more. We work with county jail and local hospitals as well, because sometimes a lot of folks that were brought to them, that they understand, hey, this person, why they're here is really due to a psychiatric or substance use need. So we work to get them the help they need, and a lot of times they'll release that person, and we're able to then provide them treatment. Recovery community organizations, of course, are a huge one too. So here's what I was going to talk about. That person is not able to, we always explain it like this. Sometimes some of us heal faster than others, and it's nothing. We always talk about in our training how important it is that we don't talk about court commitment as a punishment or as something, like we don't say, hey, you better, not to coerce people either. Hey, you better take your meds or you're going to get court committed. We talk about how important it is not to say things like that or to coerce folks or do anything like that, because what that does is stigmatizes it. I always explain to us, like, sometimes it's like just like a physical condition. You go to the hospital, some of us heal faster than others. Like for me, I may get, have a virus that caused me to be hospitalized. And, it may take me 6 days as opposed to someone else that may take them 2 days to heal, and then they're released. So sometimes we just need a little bit more time. And so when that happens, we go over with our peer workforce that are taking this training. We go over kind of that process, which we talk about the mental health examination and petition that needs to happen. We talk about how that notice of hearing has to happen. We talk about the hearing process and how, the client is going to have representation. They are able to give testimony. The provider gives testimony on to why they think that person needs further treatment. And then ultimately the judge makes that decision. We talk here too, like I had mentioned, how important it is not to coerce or use this as a anything punitive, or like they're doing something wrong and that's why this is happening. That's not what we do as peers. That's not what any provider should be doing either, no matter what your profession is within the behavioral health field. That's not what that should be looked at as. All right. We did also talk about levels of care. And these are the main ones I hit on in Oklahoma. There's, of course, we have other levels of care too that kind of exist in other, that are existing. And we have some that I'm wanting to, like, I really want respite centers in Oklahoma. We're not there yet. I cannot wait for that day. I'm hoping that it comes in the future sometime. But these are the levels of care that we have right now. We also have recovery community organizations, drop-in centers, support groups, advocacy groups too, that also fill in some of these gaps in between these levels of care too, that are outside of it. But for the sake of this training, we focus on these here. We talk about outpatient, which is in our behavioral health system, it's the lowest traditional level of care. At that service, we talk about the services that folks receive, which, psychiatry, case management, wellness services, peer support, therapy, primary care, medication, volunteering, career support, and much more. And we always talk about how the goal is to always keep people at that in the community and keep them out of those higher levels of care is the goal. Now, it's not also, it doesn't mean anything that person is doing anything wrong. Sometimes we need that higher level of care despite, doing everything that we can, doing all the things right. But sometimes we need that higher level of care, but always the goal is to keep people in the community with their loved ones and their family, living their best lives. We talk about urgent recovery centers. I'm gonna take a drink of tea here real fast. We're gonna take a break soon too. And real quick too, we're gonna break it up just a second, but how did y'all know that French fries weren't first cooked in France? They were first cooked in Greece. So I am apologizing. My kid has to live with this all the time. So urgent recovery centers in Oklahoma, this is a huge deal, and they make such a big difference. I like to describe them as kind of like a behavioral health emergency room. And so they, instead of, like beds, they have chairs, where folks are able to come in. It really, folks are, it's supposed to create, it's not supposed to be a huge process. You're not screening people to come into your urgent recovery center. You're not checking if they have insurance or they don't have insurance or all this stuff. You're just checking for those, basic things, like what are their vitals? Are they appropriate for this level of care? Are they, if somebody has like a major wound, we don't want to bring them in because they'll need to go to the hospital. So we make sure that they're medically stable enough that they're not going to have a, major issue. And so, but what this place is meant to be is a place, instead of, people aren't going to emergency rooms necessarily where they're not necessarily equipped to deal with all these things. Instead, they can bring folks to an urgent recovery center where they can start that lower level of care where they can get connected to services. I always tell people too, sometimes this is one of the greatest things because sometimes that environment, as we know, is a huge major factor in like escalating a crisis situation. Sometimes having some time to get out of that environment, talk to somebody about what's going on, whether that, talking to, a peer that's been there before that can talk about, hey, I've been there, this is okay, talking they can relate to and engage them, and talking to a therapist, who's able to assess them and talk to them about resources too. And then connecting them with a case manager who can also get them connected with resources in the community. And then have, peer support that's able to follow up with them, make sure they get connected, help with that warm handoff, even if it's immediate, like, hey, we're going to get you straight into an appointment. We're going to get you over here to, this outpatient clinic that can provide you the service. Or if they need that higher level of care, making sure that person knows that, other folks have been there too. And it's not because you're doing anything wrong. It's just because you need some help right now. But so a lot of times, majority of the time, folks are able to solve that level right here. They're not necessarily the majority of folks are not having to go to that next level of care, which would be a crisis unit. So this is like just another layer that helps prevent folks from having to go to that higher level of care, and it helps keep them in the community where we want them to be. All right. Crisis stabilization unit. Now, if someone does need to go to that higher level of care, this is where they would go. All right, we can go ahead and take a break and we can answer some questions, and then after we answer some of the questions, we can take our 10-minute break.
Thank you, Tony. So I know that we had one question that came through the chat from Renee. So Renee, if you can hear us, we would invite you to come off chat and verbally share your question if you're comfortable. If not, I am happy to read it. Do we have Renee still here? Oh. Renee, do you want me to read it? Okay, I can read it. So the question was, what services are offered at the crisis centers? Examples given: one-to-one talk intervention, overnight multi-day crisis stabilization, respite, inpatient, mobile crisis dispatch to the community, etc.
Oh yeah, we're gonna hit on that. It looks like we're hitting on some of that right now. So that's gonna be covered.
Okay, does anybody else have any other questions while we're sitting here? Feel free to unmute.
All right, well, if you have any come up, I'm gonna keep going until 2, and then we're gonna take a break. And then if you have any questions after the break too, don't hesitate, and we can also cover some at the end or on Thursday. So this is to answer some of Renee's question, and there's going to be some more answers to that too, Renee, as we keep going. But so what crisis unit, what services are provided in a crisis stabilization unit? So we talked about some of the services provided at that urgent recovery level of care, which is, assessment, peer support, case management, connecting them to resources in the community. Sometimes some brief medication is involved, and then getting connected to get more medication if that's what's needed as well. Connecting the support groups. What happens when the crisis stabilization unit, and this is when that person comes in and they're staying longer than that short period of time. Usually that urgent recovery center stay is no more than 24 hours. It used to be where it couldn't be more than 24 hours, but the IMDA waiver allows that person to stay longer than that if needed. But the goal is, to get that person stabilized and connected to resources and to that next level of care, whether that be up or down. And the crisis stabilization unit, which would be that up, what's provided there is groups, whether they be therapy groups, they may be peer support groups or educational groups. Therapy is provided, medications are provided if that's what's needed. Treatment team, you sit in a treatment team where the person-centered care, where that client is at the head of the table and leading the way. It's how it's supposed to be. Hopefully that's always is happening. Detox sometimes too. Not all crisis centers provide that level of care, but some do. Case management, discharge planning. Discharge planning happens right off the bat. We're going to talk more about that too. If you're not discharge planning right when someone gets in the crisis services, in my opinion, you're not doing it right, because that stay is short. And so if you're not already starting to plan what's the next steps right off the bat, then you're going to be behind the eight ball. 24-hour observation also is needed too. At this point level, this person is meeting imminent risk of harm to self or others. And so they're not put in this level of care unless there is a high acuity risk of harm to self or others, right? And so we're at 24 hours observation is a big key to that. We're keeping this person safe and others safe and the community safe at the same time, right? So that's a big component of this level of care, is that person is receiving that. That usually happens with 15-minute checks, and we're going to talk about that more too here later on in the training.
Tony, this is
Yeah.
Margaret from New Jersey.
Hey, Margaret.
Hi. I have concerns that these crisis stabilization centers are going to just be a little bit too medical model, and they're not gonna, actually, be consistent with SAMHSA's guidelines, with regard to the peer role being pivotal and stuff. So could you speak to that?
Yeah, well, so we've had crisis centers in Oklahoma for quite some time, since 1987. So, but they did start out more of a medical model, like Margaret, like you're mentioning. They started out that way, and some of them still probably operate more in a medical model too. but they're transitioning to being more recovery-oriented, person-centered approach. And so having peer support workers within that too, and as that has grown, I think has also played a major part of helping that environment go more towards a recovery-oriented system rather than that pure medical model. Due to sometimes, I mean, it's a process and it doesn't happen overnight, but I think it's getting there. I can understand if you all have not had crisis centers yet in New Jersey, or you're starting to build those. I can see your concern, Margaret. I hope that they're reaching out to other states so they can learn, hey, what this has been helpful, hey, this hasn't been helpful, what has worked and what hasn't. I know our commissioner, I could provide a lot of a good feedback. I'm happy to talk to anyone too. But yeah, don't hesitate to reach out, Margaret. I hope that I answered your question somewhat. But
yeah, well, in this second half, will you be talking specifically about what role the peer will be having?
yes, we do talk about that. We do, for sure. I like this guy's smile. He's got a good smile. The next level of care, as you all probably know, is that inpatient hospitalization. And according to Title 43A, which is Oklahoma's mental health law, this means the process of providing residential diagnostic and treatment services on a scheduled basis. It is more of a medical model once you get to this point, to go with what Margaret was asking. But I think Oklahoma, at least, we're trying to do a good job of making sure it's person-centered and involving a lot of recovery aspects to that too, that recovery ordinance system of care aspects. We're not perfect, but we've come a long way, and we're still moving in the right direction. All right. And I think let's see, where are we at? I'm going to keep going till 2 because we have a lot to cover here. So when I created this training, we didn't have mobile crisis response teams quite set up yet. And so this training is going to evolve more and more as, 988 evolves and our system evolves, because it's evolved a lot since I created this, which wasn't that long ago. And my team too. I didn't create it all by myself. But when I was on a mobile crisis response team, and this was when we had one that lived within that crisis center when I was leading that, and this is what also they'll be doing too, is the goal of those is to help connect, transport, sometimes provide follow-up to outpatient and substance use treatment. Sometimes they'll be providing peer recovery support, case management, assessments, therapy assessments, crisis assessments, to see if that person is needing that higher level of care. And then also crisis intervention. The goal is always to make sure to help that person solve that at the lowest level and then get them connected. Another big important component of mobile response teams and crisis response teams, as far as from my experience, is that warm handoff between levels of care, helping make sure that levels of care, that handoff between those levels of care is happening. All right, this was where we'll take a break when we were going to talk about youth mobile crisis response in Oklahoma that we share in our training too. So it is now here, it is 2 p.m. On the hour. I don't know, depending on where you're at, it might be a different time on the hour, but we're going to come back about 10 after the hour of wherever time it is where you're at, if that sounds good. And so I appreciate y'all, and I'll see y'all in about 10 minutes.
Thank you, Tony.
Recording in progress. We're good. All right. So I'm going to get going because I want to make sure we cover everything. I just want to let y'all know too, I'm probably going to wait to take questions until the very end. And if we don't get to them, please, put them in the chat or send them to us. And if for some reason we're not able to get to them, we'll get to them on Thursday. I'm just worried we're not going to cover everything, and I want to make sure we do. And this real quick, and I think it goes with our next section, which I'm going to cover pretty fast. But what did baby corn say to mama corn? Where's popcorn? All right, that's one of my favorites. So we cover youth, we go over youth crisis in our youth mobile crisis response in our training briefly too, because even though peers are, in Oklahoma, peers are able to provide services, Medicaid reimbursable service to individuals age 16 or older. So we definitely hit that transitional age of youth, but we don't provide services regarding peer support to ages lower than that. At least that's like reimbursable. So, but why we do talk about this is because they've been doing this for quite some time. We have a pretty good system as far as youth mobile crisis, and there's a lot we can learn from it. And so we talk about it because of that. We can always learn from others and what we're doing well. And youth become adults. This is our youth mobile crisis number here in Oklahoma. We talk about that. It's a good resource for peers to have, to be able to tell, folks that they work with and, family members, folks in the community that we interact with. It's a good thing to have. It's a partnership with the Department of Health and the Heartline. It's designed to support children, teens, young adults who are struggling with mental health, emotional, and behavioral health challenges at home, life, and in school. The goal is for youth and with serious emotional disturbances to have access to supports necessary to remain in their home in the community. So just like crisis services, it's to help keep folks in the community. It's staffed 24 hours a day, 7 days a week, with trained call specialists. They have mobile crisis teams too. They assess the young person's need and create a plan. If needed, they'll disperse a mobile response team. Immediate relief is provided, and call specialists follow up with the youth and family to provide long-term plans and supportive services. So the outcomes that they've had, 79% of youth and young adults were diverted from a change in placement. 90% of youth at risk of school disruption return to class. 78% of callers said that they would use the crisis call center again. That's a good one, right? And then program is data driven. So strategic decisions are made based on data analysis and interpretation, which I know Amy likes to hear. We're going to talk real quick about mobile crisis in 988. So in Oklahoma, we have this is a good image of our comprehensive crisis response. You can also, if you go to the Department of Mental Health and Substance Abuse Services, the Oklahoma Department of Mental Health and Substance Abuse Services website, you'll be able to find more of this information on there, and also some pretty cool videos explaining it too. We go over this in our crisis training. So we talk about like the different levels of care within the crisis comprehensive crisis response system. So we're going to have the 988 set up. We've partnered with a great company, which is out of Arizona. If we got any Arizonans in there, we appreciate you. We're contracting with a company called Solari, and they're going to provide our 988 hub. We have already, like I talked about earlier, we have a really good system in Oklahoma as far as CCBHCs. We were one of the CCBHCs pilot states. And like all of our community health centers have now become CCBHCs, and that's our model. And so with that, many of them have urgent recovery centers. They already have mobile crisis teams that are being set up or are already set up. And so because of this, and we're contracting with some others as well, are going to be able to provide that mobile crisis team response if it needs to get to that level of care, if they're not able to solve it at this level right here, number one. We also will have follow-up appointments that will be able to be provided by the response teams, and peers will be a big part of following up with the folks, following calls and interactions with the helpline and mobile crisis teams. We're going to have technology that's going to play a huge part, getting transportation, to those services is a big part. And then also, like I said before, we have all those urgent recovery centers and crisis centers set up across the state, and CCBHCs and those community partners within the community. So we have a robust system of, I said robust, funny, robust levels of care, different levels of care across the state, which is like makes us, I think, really prepared as 988 is rolling out, which it is right now as of July 5th. So we're excited. So we go over this for our peers because they're going to be a big integral role with that, which we're going to talk about more. We also talk about in our training what is law enforcement's role, because that's important to know. You know, we don't want to go over into that role ever, but so like when it comes to a welfare check, like if there is possibility that something dangerous or you know, we can't go into other people's homes without their permission, you know, to check on them, or we're not going to go knocking on someone's door like that we think that there may be something really dangerous going on. That would be a law enforcement's role. Putting someone in protective custody, which I'm going to talk about more. If say someone is, you know, not feeling that they need a higher level of care, but it is determined that they do, that law enforcement officer can put them in protective custody, and then we'll transport them when appropriate to an urgent recovery center or an evaluation hub to be evaluated to see if they are needing a higher level of care or to get them the resources that they need. And of course, when they intervene when the dangerous level is too high, such as like a weapon or you know, if there's a level of dangerousness, threatening harm, things like that. All right. We talk about the different levels of transportation, IMSA, police transport. We had a recently in our last session, we had a House Bill 2877 passed. What this does is, and we were really excited about it. So it takes transportation of more than 30 miles. So if it's within the 30 miles, police are still able, they still transport within that 30 miles. But if somebody is needing transport that's beyond that 30 miles, we've actually worked with contractors and vendors to provide that transportation. So we're hoping that helps reduce some of the stigma that's involved, because those of you that have had interactions with police, you know, it's not always the most fun, and it doesn't seem quite right always that, you know, we're being put in handcuffs, you know, for a behavioral health condition, and, you know, and folks having a medical condition, they're put into, you know, IMSA. I know sometimes we're doing the best we can with what we have, but we're hoping that this helps reduce some stigma and also some trauma that sometimes can happen whenever law enforcement's involved. And law enforcement really appreciates this as well, big time. This bill also helped put telehealth tablets in the hands of law enforcement, both for the people that they're interacting with in the community. They can help connect them to talking to a licensed mental health professional or somebody specialized in that, case manager or peer in the community, but they can also use it for themselves for the needs that they have too as well, because they're dealing with really stressful situations. We cover some screenings that you might see when you're working in a crisis center or a crisis level of care. We talk about Columbia screenings. These aren't all of them, but this is not all encompassing. We have a really long list, but these are some of the common ones you may see, like the Columbia screening. We talk about the PHQ-9. We talk about ACE. I know it's not a screening, but it's like you know, the ACE scores and how that affects. We cover that really well in our core training, so we barely touch on this. We talk about wellness assessments as well. So these are some important documents when it comes to emergency assessment. If someone's brought into a crisis center, say like somebody, you know, the police were called out, you know, or police needed to be called out. And this was before we had 988, which was when I wrote this, and this will still be a factor with that. But say that some police is called out and they have taken that person in protective custody. In order to take a person in protective custody, they have to do a peace officer statement, which is, it has to be written by that law enforcement officer that's putting them in protective custody. They have to, once they put them in protective custody, they have to take them to the nearest evaluation center. Usually that's a URC when it comes to Oklahoma. Prior to that, you know, sometimes it would be the crisis center itself before URCs, and sometimes it would be, you know, hospitals, depending on what's going on in that area. According to our Title 43A law, we have to evaluate that person within 12 hours. You know, so sometimes a person may be evaluated and then may need to be, you know, it may be determined that they need, you know, longer time is needed, so they'll put them like in a reevaluation status, but they have to have that initial evaluation within 12 hours if they were put in protective custody by a police officer and brought for evaluation by that provider that's doing the evaluation. The police officer's statement consists of why the officer felt that person was at risk, or why they think that that person needs to be evaluated, what was going on, that they felt that they needed to actually take that person, place them in their custody. I mean, they're looking for why they think that person was meeting criteria, possibly, or at least there was showing enough signs that there was a level of dangerousness where they needed to be removed and be evaluated. Third-party statements, these can be written by any member of the community. It's kind of like that duty to warn. And what it does is this is a serious thing too, though, because you can't just make stuff up, because if you do, you can also be, this is a legal document and you're signing off on it. This does not mean that somebody is going to be put in emergency detention status by doing this. This just is you're providing the information that caused concern to why you think that person needs to be. Because sometimes, as we all know, sometimes folks, something may be going on in the community. They may go to a place and they're able to, hide what's going on or not share what's going on, or hold it together, for that brief period of time while they're being evaluated. And we don't know sometimes what's going on in that community, and that information could be really helpful for that licensed mental health professional for making that determination. It also can help police officers. Sometimes when a police officer comes and you have a family member or loved one that's has some psychosis that's becoming to the point where it's dangerous, or they maybe have made some statements, suicidal statements, and with a plan, but then they're not sharing that with the police officer. This lets you let that police officer know that this is what that person said, and then that police officer, not you, then decides what to do with that information. And same thing with the law. So by writing third-party statement, you're not putting someone in emergency detention status. You're just providing them with the facts of what you saw in the community, and those certain facts that you felt was of concern, because you want to make sure that person's safe and that the community is safe, depending on what's going on with that individual. We also then cover what a third-party statement is, which I just kind of did already. It's vital information as to why the person is in need of help. You include current objective observations of behavior, statements, et cetera, that are cause of concern for the individual, and any history can be helpful. It's important as a peer. I know sometimes we may need to tell a family member about third-party statements. They're saying, hey, like, this is what's going on, but the police came and they aren't doing that. We're not saying that we want that person to go or that person needs help, but we're just going to let them know, like, hey, this is something, if you're seeing something and this is not what the behavior they're displaying when the police have come, then you can do this in order to make sure that the police understand that's there. And then that might help get that person the help and the resources they need. This also helps, like I said before, if that person is brought to be evaluated, it helps make sure that the most accurate information, that they're getting like all the pieces to the story. You know what I mean? Because like if someone's brought to you and you don't know what else was going on before they were brought to you, you're only getting one piece of that puzzle, and you want all the pieces of the puzzle. All right, we show what a third-party statement looks like in Oklahoma. This is just a template. We give a bad example of what a third-party statement is. We want folks to be able to explain and be able to write one well if we need to. Sometimes we might see something that nobody else sees, and we want to make sure that person, especially if it's something that's very, very dangerous or going to cause them harm, we want to make sure that that person gets the help they need. So we talk about what a bad example looks like, because I think that's helpful to know what's not good, which this one is Jane Doe needs help 3 years ago. She said she wanted to hurt herself. I think she needs inpatient treatment. Her brother told me she has been behaving strangely. We talk about why this is a bad example. This person gives information that was from a long time ago. That's not what's happening right now, which is what we need to know. She gives her opinion, or he or she, whoever, or they or them, whoever wrote this, gave their opinion, which is not what we're wanting. We're wanting objective facts. We won't, and then And then also we get like fourth party information here. Her brother told me, or third party information, which is not, we're not wanting to know what we want that person that is writing the statement. We want their observations of what's going on. And then we talk about, this is not a perfect example, but a decent one, which is pretty, it's objective and it states the facts and it states what's going on now and exactly the behaviors that we're concerning. And that's why this is a good example. We go over consumer rights in Oklahoma and how important that is. When it comes to peer support, it's a big part of our role is to advocate for the rights of consumers, to make sure those are being followed, and also empower the folks we work with to know their rights so that they can advocate for themselves. We talk about confidentiality and how important that is in our training. If you're going to be creating training or doing a training in your state or at your agency, I mean, you can't hit on confidentiality enough and how important that is. We talk about stigma. We talk about the different kinds of stigma and how big of a role that plays. Like I said, like at the beginning, I think that's one of the biggest barriers to getting into treatment, and it exists. Stigma even exists within the recovery community. Sometimes we stigmatize each other with some of the things we do. So it's so important to understand that, and so that we can do, as peers, we're stigma busters. And so we do everything we can. We talk about how the harmful effects of stigma, how this can lead to crisis many times, or exacerbate crises. We talk about ways to bust stigma, which is one thing I tried to do at the beginning when I shared my story too, like talking openly about mental health, educating others, being conscious of language, encouraging equality between physical and mental illness, showing compassion, normalizing mental health treatment, and choosing empowerment over shame. I'm a huge fan of Brene Brown. I bet y'all are too. I've never seen her in person, but if I did, I'd probably cry a little bit, totally fan out. We talk about trauma. That's a big part of this training too. We really cover this pretty deeply and hardcore, because as most of the individuals that come through our doors, my experience at the crisis center, I would say 99%, or probably 100 had experienced some significant trauma in their life. Trauma plays a huge major part in our lives, and especially when it comes to crisis services. So we talk about trauma. We talk about trauma-informed care, and trauma-informed care is usually a training most of our folks are getting to at their facilities, and through their trainings. We talk about trauma-informed care in our core training, but we also hit on it again in this training too. To make sure that we are, because that's such an important part. Just like I said, providing trauma-informed care and crisis services is a must. It is so vital, and it needs to be taught thoroughly, to not just to peers, but to any level that that's working in crisis. That needs to be a major aspect of it. Here's another quote, by that same individual. That was the Prime Minister of India that helped with that was part of the anti-colonial movement back in the 1930s. But and he says, people who are hurting don't need avoiders, protectors, or fixers. What we need are patient, loving witness, people to sit quietly and hold space for us, people to stand in helpful vigil to our pain. And I think this really fits, especially with this next part of the training that we talk about, which is the peer role in crisis care. So according to SAMHSA, the peer role in crisis care is a transformative element of recovery-oriented care that is fully engaged in the experience, capabilities, and compassion of people who have experienced mental health crisis. So this includes individuals with lived mental health and substance use disorder experience. Peers, as core members of a crisis team, supports engagement efforts through the unique power of bonding over common experiences, while adding the benefits of the peer modeling to recovery as possible. So peers are a big part of crisis care. So the role in crisis care that peers play, well, they're a beacon of hope. So as a peer recovery support specialist, which we call them in Oklahoma, or PRSS for short. So if you hear me say that from now on, I'm referring to certified peer recovery support specialists in the state of Oklahoma, if I use that acronym. But as a PRSS, your example of recovery. So recovery, your example that recovery does happen. So when someone's coming to a crisis level of care or into services, or seeking services, you're that example that recovery is possible. You're that beacon of hope. They provide that lived experience. They provide support and advocacy. And I'm going to talk about more specific roles too, but they support in addressing consumer needs, inpatient needs and issues, needs in using issues related to consumers' life outside of the crisis unit, and including the reasons for crisis. So what are some of the things that peers do where we excel at, like our sweet spots, right? Recovery plans, wellness recovery action plans, if you use that model in your state. We do a lot of recovery plans, wellness plans, relapse prevention plans, those peer scope groups, so support groups and educational groups, those are big ones. We also provide a supplemental training for our peers to their core training that is just on facilitating groups. Self-care, so we're modeling recovery for consumers. We're providing groups on self-care sometimes. We're ensuring personal mental health and well-being, and we're supporting them or meeting them where they're at. So where peers really excel and what we're doing in Oklahoma is that targeted outreach. And so we're going to those places where folks, like we're going to the shelters, we're going to those different places in the community with our community partners. We're providing that outreach to folks that, and letting them know the services that are provided. We're doing that targeted follow-up. So, and also with that outreach, say you're working at a higher level of care, a lower level of care. If you have folks that are, that are your peers or may come to you, you're outreaching to that higher or lower level of care where that folks that may need to be connected to make sure that they know your services are there so they can get to know you. And that goes with that targeted follow-up too. Like once folks leave your care, they've had an interaction or intervention with crisis team. It's so important for us to follow up with them following that. Peers are like so perfect for this because no longer are we in the days where we should be giving, like someone's discharging from us, should we be giving that person a piece of paper, right? Saying, here you go to the next step. That should not be happening. We are past that point. We have technology. We have learned that this does not work. So having somebody from, the next level of care, speaking with that person, whether that be on video, in person, on the telephone, and usually that person being a peer is a great way to go because that's our sweet spot, right? We're able to relate, meet that person where they're at. We're able to demystify like the scariness of what that next level of care is going to be and let them know like, hey, like I did this, you can do it too, And so, that's what the outreach is. And then that follow up, checking in on the, hey, like, I just want to check in on you, see how you're doing. Like, I want to make sure you're okay. That makes such a huge difference in people's lives. And it helps with that, prevent that recidivism from going to that higher level of care. It helps make sure that gap's closed, which is like that most dangerous time period, right? When folks discharge between those levels of care, they can fall in those gaps, and that's where people die. And so that's why peers, that follow up and that outreach is such an important part. And then another role is being a member of that crisis response team. So going out with that team and kind of saying, hey, like, it's kind of like that place is putting money where the mouth is, right? Like they hire people in recovery and they're out here on this team and they're meeting me where I'm at and they're able to relate and kind of de-escalate and say, hey, like, meet that person where they're at and really listen. Peers are so great at listening and not just trying, and we're going to talk more about that in a second. We're great at being de-escalators because, we're not being fake, we're being real. We're listening. We're saying, hey, like no judgment, like I got you. We're great at engagement. So being that first person people come in that they see when they come in through that door, letting them know like, hey, like this is what we're all about. We're about recovery. Like we hire people with recovery. Like, let me tell you about what this place does. And that's perfect. And then also like call center staff too, those warm lines. So for those follow-ups, like, hey, this person may not be at that point where they're needing to be assessed, where it's like crisis, but they just need that support, which we provide so well, providing that support, listening, let them know they're not alone, help them work through stuff. That's where it's at. I do want to mention too, is that sometimes when you're working, say like you're in a crisis center or in different urgent recovery center, in those settings like that, sometimes it's all hands on deck. And I always like to mention that because sometimes we get caught up like that's not my role. You know, I was the director of a crisis center, and I was plunging toilets sometimes. You know what I mean? Sometimes you gotta not now if that's all you're doing, you know, that's not necessarily what should be happening. But sometimes you're gonna be just to make sure the safety of, you know, the peers, yourself, your coworkers. It's all hands on deck. Sometimes you're gonna, if there is a situation that happens, you're gonna have to help, you know, so make sure everyone's okay over here, maybe move them away from that situation. You're gonna have to sometimes be in that situation if it becomes unsafe, you know, too, to make sure everyone's safe. So I just always like that we point that out in our training, how important that is, because I know from experience sometimes folks, and this happens with every role, not just peers, like that's not my role. Well, when it comes to crisis services, sometimes obviously I can't operate outside my scope. Like I'm not going to prescribe medication if I'm not a doctor or a nurse. I'm not going to do an assessment like that's a therapy or do a therapy group, but sometimes I'm going to be doing other things that everyone can do. That's something that is everyone is capable in scope of do. Sometimes I want to be doing that as a peer when it's crisis services. That's just how it is. That's how it is for every position, right? We're all having to do those roles sometimes. And we point that out. What will I see at a crisis center? We talk about this in our training. We talk about what they're going to be seeing, because I think that's really important. We talk about you're going to be seeing individuals seeking help, folks having possibly the worst day of their life. You're going to see some really acute symptoms of mental health and substance use. Sometimes you're going to see folks and like that. You see folks on their worst day having those most extreme symptoms, and that's why they're there. We're there to help. And so you just have to be cognizant of that and understand, like, and not take things personally. Understand your own triggers, you know, and things that, you know, you're able to deal with and how you react in those situations. Have a really good really good understanding of your coping skills and how to use those and have those tools in your tool belt to bring up when you need to, because and you're going to hear and see and be around a lot of very acute, and that's why they're there. That's why we work in that. So, and that's why we're going to talk about too, why self-care and knowing yourself is so important. In our training, we cover who will our team members be. You're going to be working with psychiatrists, nurse practitioners, therapists, case managers, wellness coaches, mental health technicians, patient care assistants, which is what we call in Oklahoma, like mental health tech, registered nurses, licensed LPNs, and then of course other PRSSs. And there's more that I did not mention. You know, you could include like the folks that are you know, housekeeping and things like that too. The community, but these are usually the team members you'll be working with. And it's important when we cover, like, you know, having professional skills and making sure how those interactions be and how each role is important. You know, we're all an important part of this process. No job is necessarily more important than the other job. We all work together, and that's what makes, you know, you got to have all the pieces for that engine to work, right? Then we go over that too. We talk about the shifts and the difference between those shifts. I think that's really important when you work in a crisis unit to understand that. Those differences and know what you're getting yourself into. So that's why we talk about it. I'm not going to hit on this too hard, but usually, you know, these are some of the things you'll see. Like, administration is not usually there during these later shifts. Autonomy is really needed. You have to be really make sure you're adhering to policy and procedure during this time. And a lot of times folks are really active during this time too. We talked about too those special precautions, which was a question we talked about, which was mentioned earlier. And so there's that time sometimes consumers need that higher level of observation. And it's not, like I said, it's not because it's not a punishment. It's never should be a punishment. If it ever is used for a punishment, I'm hoping that in your organizations, which we do within ours, like there is a reporting process. That would be mistreatment. And so we have a reporting process, and that should be reported right away, which we let our folks know. But the only time this is used is in order to maintain safety for that individual or other individuals that are on the unit or in that level of care. So it has to be ordered by the physician. The nurse may order it, but then it has to get that physician approval within a certain period of time. That's how it is, at least in Oklahoma structure. The most special precautions should never be used to be punitive. I already said that. That's so important. And then policy and procedures for the special precaution should be followed exactly as prescribed. It's like, it'd be like if you don't follow the special precaution, just as it was written. It's like, it would be like if you were a nurse giving someone, deciding on your own only to give that person half the medication because you think that's what's best. I mean, you know more than the doctor, right? You don't want to do that. That could cause some major harm. That's how people get hurt. Usually the most standard precaution, at least how we do it here in Oklahoma, is that 15-minute check. So that is that standard observation. So somebody that's coming into a crisis unit, stabilization unit, or into an urgent recovery center or inpatient, they're getting that no matter what, they're getting that standard observation. So that person is eyes are being laid on that staff every 15 minutes. And there's a lot of components to that too. You're not just looking at them, you're actually ensuring that the person's breathing, that they're medically stable. I've seen a lot of lives saved because of these 15-minute checks, you know, so I've seen that so many times, that like people did not die because staff were doing what they're supposed to. It has to be charted and stored per your facility's record keeping policy. You have to abide by the facility's policy and procedure for this. And like I said before, it saves lives. We really hit on this big time because it's so important. Examples of special precautions are those CLOPs. Another higher level would be like close observation or line of sight at all times. So sometimes folks, due to different reasons, which we're going to talk about, you have to have them in your sight at all times. There's also a one-to-one. Usually what that means, you can write it differently, but usually that means that person's within arm's length. That's because usually there's different reasons, which we'll talk about soon. And you have to chart on that per your policy. Sometimes they may write it where it's within 10 feet, different reasons, and doctors will do that depending on what the need is. But that one-to-one means that person's at a high enough level. I've seen 2-to-1s at times. That's another one that I've seen 3-to-1s. I've seen like 4-to-1s at times being necessary. And that's to make sure that person's safe, not only for themselves, but maybe others too, depending on what's going on with that person due to what they're experiencing. All right. Here's some reasons for that higher monitoring level, but it's not necessarily limited to this. And some of these are assaultive and aggressive behavior, disorganized behavior, elopement, falls, medical conditions, seizures, also suicide prevention, or self-harm precautions. These are all reasons that they may be placed on those level of care that I mentioned before, like that one-to-one line of sight. So with seizures, they might need to be on a one-to-one because if they're about to fall, we got to make sure that they're not going to hurt themselves. Things like that. Somebody that might be experiencing some delusions or hallucinations causing them to, try to hurt other people or themselves, they might need to be put on that too. Those are all examples. And like I said before, it's always the least restrictive environment. And that goes with precautions. Not only is it in the level of care that needs to be if somebody going to crisis center, that needs to be that least restrictive option to keep them safe, but also goes while they're within that treatment, any services that are provided that are like a higher level of care, that they need to be the least restrictive. So as soon as that person is no longer needing that extra precaution, they should be taken off of that. All right. We then cover de-escalation in our training, and this is a big important part. Like I said before, this is not their de-escalation training that they should have as, that when we're doing this with our peers in this training, this is not like the end-all de-escalation training. They should also be getting this at their facilities. We require that within our contracts with our providers, that they're providing that. The most common one we use here is therapeutic options. We do have some other agencies that use some different ones too, but that's the most common one. We talk about navigating consumer symptoms. We talk about psychosis and what they'll see when, when consumers are experiencing that. We talk about some instances. We talk about substance-induced psychosis. We talked about and the differences sometimes, and sometimes it's hard to tell. We talk about ideation and intensity. We talk about mania, and we talk about depression. We talk about prevention, which is the key to de-escalation, right? If we can prevent it from happening, oh my gosh, that's so important. And we talk about ways to prevent that. I talk about, hey, being out there interacting. Whenever I worked whenever I was director of a crisis center, one of my biggest pet peeves is when folks would, be talking to their coworkers and not out interacting, doing that recovery-oriented system of care. They're just sitting behind here talking, not doing that's how you're going to make your life really hard if you're doing that's how bad things happen. So that's a big deal, but prevention. But other ways to prevent is making sure you're doing trauma-informed approaches. That's not that hard, right? Most of these things seem real simple, but sometimes they escape us for some reason. So we really harp on these. Helping maintain a safer environment, listening, non-judgment, sharing power, avoiding power struggles. I understand it's important to follow rules and everything like that, but you don't have to be right. It doesn't make sense to always have to be right. Sharing that power as much as you can, that's a big deal. Imagine, that's usually why folks start to escalate, is they feel all their power is being taken away. And that's why it's so important. So I've seen situations that didn't need to happen just because, you know, the person, the behavioral health professional felt that they needed to be right in a situation they didn't have to be, right? Connecting with that person, that's so important, to empathy and respect. But sometimes, despite our best efforts, the prevention escalation crisis happens, and we are called to respond if it's already escalated. In these circumstances, it's vital that we're prepared in order to keep yourself and others safe. So it's important to be aware of the environment. I give an anecdote of a dumb thing I did one time, and in our training, which was like, I was not aware of my environment. I walked up really, I thought I was not aware of my environment. The person had a weapon that they had gotten from breaking a chair, and I walked right up to that person. Luckily, it was a good situation, and that person did set it down and give it to me, but shouldn't have done that. And so I always like to give, you know, dumb things I've done to let them know, like, hey, don't do that. It could have ended really badly. We talk about being aware of your environment, which I was not in that situation. We talk about looking for danger. This goes both in, you know, those crisis stabilization units settings, but also if you're responding in the community, these are all vital in those situations too. Talk about looking for weapons, objects, other people. We don't always know. There may be someone else that's there that we didn't know was there. So we need to be cognizant of that. If you're talking to someone and you're not worrying what's going on around you, that's not a good thing either. That's how you can get yourself in a bad situation too. Keeping a safe distance. So that's part about being trauma informed. Getting up in someone's space that's starting to escalate, it's a really, really bad idea. We go over that pretty big time in the training. We talk about not being alone and responding as a team, and then also knowing your exits. This is like my soapbox I always get on. I always talk about too, like I'm a clinician, but I'm a peer too, and I think clinicians sometimes are the worst at this for some reason. If you're a clinician on here, I'm sorry, you can disagree with me, but it's true. But sometimes we think we can talk everyone down. That's not really the way it works. Usually, like we talked about too, with those stages of crisis, a lot of times if somebody's already escalated to that point, trying to rationalize with that person is not very rational yourself for trying to do that, because they're not able to do that at that point, right? So the best thing you can do is listen, hear what's going on, be empathetic, show compassion. So that's why I have this quote here. When it comes to crisis de-escalation, we need to change our way of thinking from talking someone down to listening someone down. This seems to really hit with our folks too. They like that. It makes sense. And I think that really, why peers excel a lot of times in crisis services. So we talk about preventing escalation, which is listening with your ears and eyes. We talk about listening to what the individual is saying or trying to say, we're looking at, like, not just looking at what they're saying, but also like how they're breathing. Is it rapid? We're watching for those nonverbal communications, like clenched fist pacing, hands waving in there. That's a big tell, right? We talk about how to provide support. So we're validating the person's feelings. We're being empathetic. We're not showing judgment. We're using lived experience when appropriate. I mean, we talk about how it's so important to be authentic and honest. And that's why peers are so good. Because, like, one of the worst things I know from my experience when getting treatment is when I feel like someone's talking down to me or talking to me like a baby or being fake or whatever they're doing. That doesn't work well. Peers are great. We're authentic and honest, right? We're being ourselves, and we're providing all these things while doing that. And letting folks know it's safe. That's a big thing. A lot of times why sometimes things escalate is because they don't feel safe. They don't feel heard. Patience. I can't talk about it enough. Like, sometimes I know, like, it's unfun. Sometimes it's uncomfortable, dealing with those situations, especially if they're lasting a long time. But if you get impatient, that's when bad things usually happen. So we got to be patient. Let it unfold. Like, sometimes it's going to take a long time, right? That's okay. The key thing is we don't want it to escalate and then folks get hurt. Here's some helpful tips we give in the training too. And like we hit on these way more in depth than I am right now, but because we're running out of time for sure. But like redirection, that's a big one. After listening, asking that person to sit down. We talk about how like a big part, like just like sitting down, like has this physical effect that helps us calm down, right? Not telling the person to sit down, that's not a good idea, right? When they're upset, but once it gets to if you can see the right time, like one of the times I would do is I would just go and sit down and like start listening to them, and they would come and sit down, and it like almost half the battle was done just then. Model calm. Like we start to, when we see people being like, we just like whenever someone starts to escalate, we have to be cognizant of not escalating too, because we tend to mirror, and our brains are just, that's what we do. It's instinctual, but we can also help them by being cognizant, modeling that calm. They'll start to calm down too, many times, not always, but it's helpful. Calm breaths, doing that, modeling that, relaxed stance, being your authentic self. Don't assume you know them. Don't assume you know what's going on. Listen to them. Let them tell you. When you start assuming and you tell them you know what's going on and it's not the fact, that usually doesn't go well either. And of course, listen. I already mentioned this too. Make sure you're being mindful of your reactions. If you have like that face where you're like, oh, whenever that person's having a thing, that's probably not going to go well. Make sure that you're, being empathetic and understanding and supportive with your face. I know sometimes it's hard, but we got to be mindful of that. Make sure that we're not causing them, causing them to feel uncomfortable or judged. Be mindful of your triggers is really important too, and being present in the moment. If you start thinking about what you want for dinner later that night, in the midst of a crisis situation, that's how folks get hurt too. We do some training role plays. And these are real important. One that we give them examples of a situation that's happening. Sometimes we break out into breakout groups, and sometimes we'll do it as a whole group, and then we break out into breakout groups after to discuss too, and kind of go over ways. We talk about how important it is not to stigmatize when we're doing these, not to try to be funny and like do a stigmatizing thing, like acting like a client or whatever. Which we don't have to worry about much with our folks. But we do go over that, how important that is. We have a trainer in each one of those groups too when we're doing this. Again, we talk about those discharge planning and handoffs. I already mentioned this, so I'm not going to mention it again. But those warm handoffs and discharge planning from day one is so important. We go over the communication that happens between folks, and how important that is. So we talk about how our communication with family members, because how important that is, and how understanding where they're coming from is so important too. Like, yes, they may be mad, they may be yelling at us, but why do you think they're yelling at you? Because they're scared, they're upset, they're worried about their family member. That's why. We talk about interacting with our coworkers, how important it is, and we have to be cognizant of the fact that they're doing the best they can and giving them grace, and their role is different than ours sometimes, right? And so we can't assume that they know what our role is all the time, and that they know what we're doing all this time. We have to be able to work as a team, understanding each part is important, and then have those active listening skills and those communication skills and how important that is. So we really go over the importance of communication skills in this. And we sometimes we're interacting with judges and lawyers, that happens, community partners, law enforcement, consumers. We go over all that. This is a little quiz I do for a check-in sometimes in the training. So if, a family member is very upset with things and taking so long and doesn't understand why they have to do so much intake paperwork. The situation, you should be rude back, ignore them, and then C, that's the right answer. Or go tell your supervisor, which is not always the wrong answer, but I hope that we always want to empower our folks to you don't have to go, if you're going to your supervisor for every time that happens, your supervisor might just have to sit up there too and be engaging folks in the services rather than you. That's going to happen a lot. Self-care. We hit on self-care, and I'm not going to talk about this because y'all know about self-care, but we cover self-care and why it's so important. We cover all these things here, why it's so important, like covering self-care in your training that you're doing self-care constantly with your folks that are peers working in crisis center and other levels of staff too. That's so important because crisis care work is hard. I've been burnt out before. You can get there, because we want to help everyone, right? And we got to have boundaries. And so we cover that, why boundaries are so important. We talk about boundaries with their job, and then we also talk about boundaries with clients. Here's some videos. I don't think we're gonna have time to do these, but we'll send these out. We might be able to actually show them on Thursday. These are some cool videos of folks that have lived experience receiving crisis care, and then folks with lived experience working in crisis care that we show during the training. And so they're really inspiring and cool. You're actually gonna hear from Susie on Thursday, who is in one of these videos, and also Tyler Ross. And Tyler Ross had a lot of, Susie has experience getting crisis services and then also working in crisis services forever. She's an OG. She's been around for a long time. I actually, when I was the community response team lead, she was the peer that worked on our team with me. Great. And then Tyler, he works at a recovery community organization. He lives with schizophrenia, also substance use issues, and he had a lot of interactions, which he's going to talk to y'all about on Thursday with crisis services and law enforcement and getting taken to crisis centers and all that's like. Yes, and Danielle, we'll get you those links to those videos. Real quick too. So as of the end of June 2022, we've had 5 trainings so far that we've done on this training that we've done. It's a 2-day training, like I said. We cover everything real in depth. These are when they've taken place so far. We've had 128 Oklahoma peers that have completed the training, and our results have been pretty good. Like some of the majority, not everyone, but the majority of folks have said that their prior knowledge increased from what they had before to the end of the training. A lot of them, it was significant. Most folks felt some of the comments like that I got was, this class is terrific. I love this training. I work in crisis and learned so many new things. Like it was very well balanced. And so we've gotten really positive feedback. I want to go over, these are the references to what we use in our training, and specifically to what I showed you that we use that was in this presentation. You'll get a copy of these slides as well. And those slides should include the link to that stuff. And so I think we have 2 minutes left, so there's not a lot of time for questions, but they've been collecting those, and you can also ask them on Thursday too if we missed any. And I just want to say thank you. This is my email. Feel free to email me if you have any questions. I'm going to put my personal email too in here as well, and you're welcome to email that too. I'm going to put that in the chat. Feel free to email me anytime. I'll get back to you as soon as I can. I oversee peer support, but I also have other things I oversee too. I oversee our employee assistance program and stuff, and some other certifications and things like that. So I'm a real busy guy, but I really like getting back with people, so I do. But if it's not like rapid fast, give me some grace. I appreciate y'all. So here is the last part about part 2 that y'all need to know. And I think they put that in the chat box. And all right, I'll let Amy or Kelly or Paige finish this off. But I really appreciate y'all. Y'all are amazing. I have more bad dad jokes, but had to rush, so I'm sorry y'all didn't get to hear those, or you might be really thankful.
Thank you so much, Tony, for such an excellent presentation. As we've mentioned, there is a part 2 on Thursday, July 14th from 1 to 2 p.m. Eastern time. Hopefully you're able to register with the links in the chat box. If not, feel free to send me an email and I'm happy to send you the link. Thank you again, and please stay on the line to take a brief survey, and we hope to see you all on Thursday. Thank you. Bye, Tony. Thanks, everyone.